gluten-free prescribing and IVF, and clearly that's a matter that should be dealt with in public. We don't have any members of the public present, but I know there are a large number on the screen, and we've got some questions relating to it. So that's fine. Apologies from Damien Allen, Mark Brooks, Lee Althwaite, but Jackie's here. Well, nice to see you, Jackie. Any others? Well, we don't think so. Declaration of interest. We have the normal ones. Can I say something about declaration of interest? Because I spoke to a couple of you, and many of us, myself included, will be affected. Our family will be by some of the issues by either IVF or gluten-free, or indeed both. And I think that's why we're members of the board. I don't propose that we actually have to declare every member of family who's either on gluten-free prescribing or going through IVF or whatever. Actually, because we're members of the public who are recipients of those services, is partly why we're on the board. So if there's a very particular issue you feel you need to join the discussion, I'm happy that you do it. But I'm proposing that we don't do that, because all of us are. I know I am. But actually, I don't think it's an issue. But it's why I'm on the board, because my family have some experience of these services in South Yorkshire. And I don't think any of us are not in that situation. So at the moment, I'm saying no need to declare that as an interest. It's part of why you're on the board. I think it's what we bring to a board. Thank you for that. We've got questions from the public, and I think I'm going to ask that we do with them differently. So we've got a question relating to gluten-free and questions relating to IVF. Normally, we read them out and then we read the answers out. I don't think today that will help the discussion. So what I'm going to ask Andy to do is, at the start of the gluten-free discussion, read the questions on gluten-free out. And at the end of that discussion, we can say, do we think we've answered those questions? And then we'll move on to IVF and we'll do the same thing. I think that's a better way of shaping our discussion rather than dealing with these as a separate issue. So I know that's not the way we normally do it, but given that they all relate to either gluten-free or IVF, I thought that would actually stimulate a better discussion. So if you're comfortable with that, I want to ask Andy to read the questions out now. Okay. So we get on to the meat of the agenda, which is the two agenda items. And we're going to start off with gluten-free. Can I suggest Andy reads the questions out before you start, David?
I just want to give a brief introduction of how we got to these items on here, just before we get to the...
Okay, and then, yeah, happy with you do that.
So thank you, everybody. In early 2023, the board considered and approved and aligned commissioning policies across South Yorkshire. You may be aware that prior to that, the four former DTGs had slightly different arrangements. The current position for prescribing of gluten-free products to the Celiac UK guidelines in England and to NHS-funded IVF cycles were agreed by us at that time. In 2024, the ICB was required by NHS England to participate in an investigative intervention process in regards to financial plan review targets. And as part of that process, a long list of difficult decisions were undertaken. Gluten-free prescribing and IVF cycles were two of the ones that we've taken forward. And the background of that was the ICB was seen as an outlier compared to the majority of ICBs across the country. As you will see today, the considerations have been presented to the South Yorkshire, Basset Law and North Derbyshire Joint Health Ovarian Scrutiny Committee in summer. And as a result of that, we did go up for a full involvement exercise, which Katie will pick up through each of the items. We presented back to the Joint Health Ovarian Scrutiny Committee following that, and we've discussed the proposals within the ICB executive, and there are some recommendations that the board are asked to consider. And yesterday, Katie and I presented to the QIPI Internal Assurance Committee the involvement exercise and impact assessment, and there's been able to comment on that. So that was a bit of an introduction of why these items are on the agenda today. So if we could go into day one.
Would you then, Andy, talk to the questions on gluten-free first?
Yes, absolutely. So the first question is from Mr. Kim Cox, who's unable to attend the meeting today. His question is very much, has the board investigated and considered introducing gluten-free supermarket voucher scheme introduced in February 2016 by NHS Vale of York CCG? And if so, what is the outcome of the investigation? And if it has not been investigated or considered, can the board please explain why not? So that's the first question.
Yeah.
The second question from Tristan Humphreys, and I think Mr. Humphreys is joining us online today. He's the Head of Advocacy and Public Affairs at Celiac UK. He has two questions. The first is, the report in front of the board clearly highlights that removal of gluten-free prescribing risks widening health inequalities, would contradict the ICB's duty under the Health and Care Act 2022, and is opposed by a significant majority of patients consulted. How can the ICB therefore justify recommending this as its preferred model? And part two of his question really is, the paper in front of the board recommends mitigating measures in the form of improved patient information, and this would be needed to counter health inequality impacts. Yet the board is being asked to approve removal of provision without any clarity on what these mitigations will be. Can the ICB give any concrete examples of new mitigations or processes that will specifically address those struggling financially as a result of these changes? Will any additional resources be provided to dietetics to support delivery of this improved information and education for patients? And very lastly, a question from Susan Davies, who unfortunately can't attend due to a health appointment herself, but she outlines her own personal experiences. She says she was told approximately 3 years ago by a member of the Rotherham Integrated Care Board, so it must be the Rotherham team, that under NHS guidelines, if a person needed certain prescriptions to keep themselves healthy, well and fit, then that prescription should be made available on the NHS. Have those guidelines changed? She goes on to outline that she sees her prescription for celiac foods as keeping her healthy and well. It's not a choice, it is a medical condition, celiac disease, and she follows strict gluten-free diet. That prescription that is potentially being withdrawn keeps her well and free from illness. And she says that she wouldn't be able to afford the foods that she needs to keep her well. And she concludes with, long term, she knows it will cost the NHS a lot more money when she becomes unwell, and she does hope that we will reconsider our decision to withdraw celiac prescriptions. So those are the questions, Peter.
Thank you. And as I said, what I want to make sure is that we as a board are confident we've addressed those questions. I think that's the point of doing it that way around. David, can I hand over to you and go through the presentation, and then we'll open the discussions out for the board. David.
So the paper is here, and I hope everybody's had a chance to read it. I just want to pull out, to set the scene, just some brief introductions. So I think we all agree that celiac disease is a lifelong condition. I think that's not debated, and the treatment for celiac disease and its associated conditions is a gluten-free diet. The NHS does make recommendations that the advisory committee for borderline substances, and this is where it's slightly different than prescription, because this is a food supplement product, is available for people who fall under certain categories. In South Yorkshire, we have about 0.5% of the population who've been identified with celiac disease. That's probably not as many people who have celiac disease. So I think one of the things about raising awareness today, alongside the decision we're going to come to, is that, you know, hopefully we have made clinicians and the population more aware of celiac disease, so that we can consider it as a differential diagnosis for people who may have symptoms currently. We include the cost of the spend as it is, and it's in circa £450,000. We do have some difference of uptake of that. Not everybody who's identified with celiac disease has a prescription for gluten-free products. South Yorkshire currently is the 4th highest provider of gluten-free items on prescription. When we made the decision last time as a board in 2023, we did see quite a significant increase in people accessing that. I think probably at this stage, we'll bring Katie to say we've done an involvement exercise, which we've got some themes that people felt were important to themselves. So Katie, you mind just bring it on?
So the involvement exercise on gluten-free prescribing ran for 12 weeks from the 28th of July to the 17th of October, and it did generate extensive feedback from patients, the public, professionals, advocacy groups and the public. Feedback received includes 1,117 responses to an online survey, 16 pieces of direct correspondence and a small number of social media comments and telephone one-to-one and focus group conversations. 63% of respondents to the survey indicated that their preferred option was option 2, provide gluten-free breads and mixes to Celiac UK guidelines for England. 14% preferred option 1, stop providing gluten-free prescribing except for the most at risk of becoming malnourished by not adhering to a gluten-free diet. 9% preferred other option, and from the comments we can see that other option included some people who said don't prescribe at all and others who said please look at alternative models such as the voucher scheme. And then there were lower percentages for the option that was recommended originally by the paper, which was to prescribe to Celiac UK guidelines for those under 18, and then the other option, which was provide to 75% of Celiac UK guidelines. Those who responded in other ways other than the survey were not asked their preference of option, but all except 3 social media comments were against changes to the current approach, which is most in line with option 2. The following key themes were taken from the analysis of both the survey's qualitative question responses and the feedback we received from other means. And I hope everybody's had a chance to read the paper, because there's a really long report and there's a lot in there. People really wanted to tell their stories and give their opinions and really bring to life how this affects them. So I'm not going to pick out any of the stories because I don't feel like I would do them justice, and I hope everybody's had a chance to read them. So this is just the key themes that came out of those stories. So the first one was medical necessity and health impact. People told us that celiac disease and dermatitis, I always pronounce that wrong, are lifelong autoimmune conditions requiring strict gluten-free diets. Their diet is not a lifestyle choice, but the only treatment available, and that removing prescription risks malnutrition, complications, and increased NHS costs. The second theme was cost and affordability. People asked us to know that gluten-free products are 2 to 7 times more expensive than standard equivalents, and that people on low incomes will be under increased financial strain. Prescriptions help to mitigate inequality and prevent difficult choices between food and essentials. And I think people were quite sensible in their approach to that, because obviously we are only talking about the prescriptions subsidising bread and mixes. It's not the whole of the diet, but people were talking about the fact that their food shops are much more expensive than food shops for people who can eat gluten-containing foods, and the prescription for bread and mixes just helps just that little bit. The third theme was inequality and vulnerability. People felt that reductions disproportionately affect elderly people, disabled, children, and people who live in deprived areas, which is a substantial proportion of South Yorkshire. The next theme was quality, choice and access. It was noted that access to supermarket products have improved, but access still remains uneven, and that prescriptions offer consistency and safety for those with mobility or transport issues. And one of the themes that came out of that was that people could generally get gluten-free bread from the supermarket, for example, but quite often it was white bread. And if they wanted a healthier alternative, that's when they went to their prescriptions. People also noted the emotional and psychological impact of managing their condition, including stress, anxiety, depression and isolation. And I think you'll have seen in these stories, there's quite a lot around people having, not going out for meals because of fear that the restaurants won't, even if they tell them they will cater for it, they won't cater for it to the level that people with celiac disease need, in terms of people describing having different toasters and different workstations at home to their family members because of the risk of cross-contamination. As we've mentioned, alternative models and solutions, such as the subsidy card system recently implemented in Wales, were widely talked about. And then the final theme was about products being more widely available. Of survey respondents, 28% did feel that gluten-free products are more widely available in supermarkets now, and therefore prescriptions may not be widely needed. Some of these respondents were advocating for an alternative, such as lobbying supermarkets to reduce costs. Some felt it was unfair to provide gluten-free products on prescription when other medical conditions requiring free-from diets are not supported. So those are the key.
Thank you.
Thank you.
Thank you, Katie.
As a result of the involvement exercise, the original options that we put forward were altered, and we did take feedback, and they were based on the age distribution. We removed one of the options, which was 75% of the celiac's UK guidelines, because we felt that didn't add anything different. Alongside that, we did undertake an equality, quality, health impact assessment, and that went to the panel, and we received feedback from there. The summary of that was that there is a moderate risk to impact on quality and there is a high impact on inequalities, as has been raised by public questions. As a result of that, we also included, or we changed the wording of exceptionality, within the option that's been put to the board today. There is a clause that allows some flexibility within within prescribers for those people who would be at risk of becoming ill from not adhering to the diet. We picked up the question about the mechanisms of receiving prescriptions, so the Wales scheme and the voucher scheme was referenced. We didn't think that was an option in itself. That's a way that people receive the prescription rather than that. And Gov, I'm just going to bring you in here if you would mind just giving us a bit of a summary of what you found.
No problem. So I've added some information to the paper itself about the Welsh card scheme and some of one of the schemes to access medication via pharmacies directly. So the main aspect of the Welsh scheme is that it's a national scheme backed by Welsh government resources that gives national infrastructure in terms of IT and national card platform with national negotiation of those, as well as commissioning of any governance arrangements around there. So that for South Yorkshire ICB would have to be managed and procured within ourselves if that was the case. Those resources will be needed as well as additional funding. So from the feedback we got from patients, some of the patients noted that they didn't choose prescriptions because of the taste of the bread that was given and some of the flour mixes. So assuming that a scheme could allow patients to have any of the range possible, potentially more patients will be accessing that. So there'd be an increase in the number of patients that would access vouchers. So that would be an increase in what we've got already. Also, the Welsh scheme, it's a national scheme based on reducing GP appointments by going through and pharmacy workload. However, there's no evidence to suggest that that could be replicated in the same way in an ICB in England. So it's not that easy to transfer the rationale behind the national Welsh scheme to just a South Yorkshire ICB. So that's the summary of that. In terms of the Vale of York voucher scheme, looking at documentation from the Vale of York evaluated their own evidence and their own feedback from what happened in there, and they discontinued their own scheme, quoting that when the pilot was evaluated, it was identified that 1/3 of the cards appeared not to be regularly used. There were governance concerns around cards being vulnerable to misuse, which CCG wasn't able to fully mitigate. And additionally, there was significant administrative burden to the CCG associated with processing applications for and loading the top of the card. So for the Welsh scheme, when they tried to, for the York scheme, when they evaluated it, they had to stop their own scheme because it wasn't viable for themselves. So I took that to say, okay, that scheme was parked for that reason.
Thank you.
We would have welcomed a national scheme. I think it's fair to say we're quite envious of Wales taking as a devolved country taking that approach, but that's not within our gift today. It's been raised about our duties as an ICB with regards to health inequalities and quality outcomes. They sit along our financial duties as well, and I think this is the thing we need to balance as a board to come to our decision, is that they're not either or, they're something that we have to see together. There are two prompts, and we've touched on them. It's about whatever decision we make today, there will be some implementation required because we do have a number of people who are already on prescriptions that we need to manage. And the second thing is the commitment to JOSC yesterday and the board is that, whatever we do, we need to monitor the impact of that to ensure that, any unintended consequences are identified and we can review our decision. So Piers, I was going to pause there. That was really to talk through the process. As you see, there's been a lot of time and effort put into this and considering all the aspects of this. So I'd like to open well.
So let's open it for questions to the board, and then we'll come back and I want to do two things. One is I want to check that we've answered all the questions that we've had, and then pick up any issues that are still outstanding. Leslie first.
Thanks, Piers. Just to confirm, in terms of scrutiny of the work that's been done towards this, all non-executive members have had sight of the full consultation document for a few weeks, so we've all had time to have a look at it properly. And we did at the Quality and Patient Involvement and Experience Committee yesterday, spend quite a bit of time just talking about this as well. In addition, David did do a briefing for all non-executive members last week where we were able to ask questions and get underneath this. So I just wanted to stress that, you know, this has been taken really seriously, and we wanted to scrutinise the work that's been done. As a result of that, I mean, we were happy yesterday quickly that the consultation exercise that was undertaken was really robust, but noted that actually some of the decision options proposed were in contravention of what people had really said to us that they, you know, they would like to see happening and their preferred options and their views. So I just wanted to say that. And then I've got a question, if I may. David, you mentioned exceptionality, and I just wonder if the people who are not in the system, you could just explain what that means in terms of mitigation for people who might be suffering some of the kind of worst end of impacts as a result.
In South Yorkshire and at Sheffield Teaching Hospital, we do have the refractory celiac clinic. It treats about 1% of people with celiac disease who, you know, their adherence isn't, they aren't able to adhere to the diet as they would normally do, and they do have consequences. So then those would be a subgroup that we would say is kind of, you know, the consultant and the clinic and the dietitians would give a steer on, you know, the requirement for, you know, potentially being classed as most at risk of clinical harm by not adhering to a gluten-free diet. So that's a bit of an example on that.
So yeah, it's those that are most clinically risk of being harmed by this. So individual clinicians can make that choice if they choose. However, like David said, we have a secondary care unit for patients that are most at risk of this, and they would be asked to get guidance from them about which way to go with this.
Can I just?
Yeah, then I've got Greg to come in. I can see you, Greg, don't worry.
So if my GP felt that I was suffering harm as a result of that, and I discussed it with my GP, can my I don't have to, do I have to go to secondary care service, or can my GP help me with that?
I think GPs would want to seek guidance on that personally. I can't speak for them, but I think they'd want to seek guidance as to what to do in that situation.
Greg.
Thanks. Two points. One on exceptionality. But first one, thank you for the update on Wales and the Vale of York. That was really helpful. That changed my view actually. So thank you for that. On the exceptionality thing, just to sort of probe a bit further, sort of exceptionality should be vanishingly small number of people, significantly different to reference population, and significantly greater capacity benefit, I think is the standard definition. I guess what's to guard against all of a sudden everyone being judged as exceptional once the consulting room door is closed, and the sort of the practical application of this in practice, and will it or won't it, and I think you may not be able to say, create additional work pressure for primary care where most of the patient volume is seen. And that worries me a lot actually, and urges me away from the option one, I think, which was the exceptionality type of clause.
David, I'll ask one to you, Lisa. Is that all right?
I think option one was to differentiate between that we couldn't see a total blanket of no prescribing of gluten. That's what that's supposed to, you know, acknowledge. Across South Yorkshire, we've had different commissioning arrangements for this. So Sheffield have been in a similar position to this in the past, and it worked. So the definition and the clause is similar to what was previously in existence. So we believe that clinicians, and I've mentioned prescribers, that we will give some autonomy to make a decision. Now, you're right, that could be open to interpretation. We may see variation. But we felt that, you know, those clinicians who are looking after the patients are probably best placed to make that decision. So we're saying is that we will not routinely prescribe gluten-free products, but we accept that there may be a small number of people who continue to do that. And when you look at the comparisons across all the ICBs, I think there's one or two who look like they've got close to zero. Most of them are at a low level prescribing, and I think that encompasses it. How we enact it, we tried to come up with a different term of words, but we felt from a board paper point of view is we have to have some trust in our clinicians, and we will follow that up with some consideration. So we've looked at groups like pregnant ladies, we looked at groups of learning disability, but we felt putting a long list of things would be helpful. Yeah. We felt we would like to keep it much broader to allow that to happen.
Lisa.
I was just thinking about other services that are quite restricted, like tonsillectomies, you have to have so many within a week. Could there be some criteria for people to judge exceptionality with some kind of symptoms or something, or some guidance that people can use that kind of standardizes things a little bit?
I mean, that could be something we looked at, but once again, you know, as I've just described, we felt there needs to be some flexibility and some autonomy from the clinicians to do that. Now, as I said, our dietitians, through the conversations we had, seemed very well placed to make a recommendation. So if you look at supplement foods, such as you know, the shakes and the drinks, we rely on dietitians giving that. So it's not, you know, most GPs will not prescribe that, but if somebody's had a muscle and they've been assessed, so we were thinking along that lines where some considerations being had.
Yes.
Thank you. Any other questions from the board? Can I just, Kevin?
Thank you, Chair. I'd like to echo Leslie's thanks to our people who have worked on this in terms of the engagement and the consultation exercise. Clearly, from what we heard, it's not been easy for our people either. So pass on our thanks to that. I was taken by some of the feedback in the consultation around our ability, or why don't we influence the position nationally. I'm conscious that us and ICB, like many ICBs, are facing downward pressure on cost, and many ICBs are making local decisions in this and other areas. And I guess this comment relates to the next item as well. But it may well be that some of the solutions may be nationally focused in terms of direction, and or in territories that are beyond health to support people with this disease. So in reality, what can we do as an ICB? I use the term that was used in consultation, to lobby those upstairs to actually have a greater focused national solution on this.
Can I pick that up a bit as the chair, I suppose? I mean, I think the answer is that's really difficult. Can we all be honest with each other? There is huge downward pressure on all NHS budgets. Let's be clear, that's why we're in these discussions today on both issues. And I don't see any willingness to debate, but to do more. I certainly see no willingness to widen services out. Fascinating, isn't it? We're the fourth highest prescriber. Most people have done this. When we come on to IVF, it's a very similar picture. And at the moment, I think the NHS budgets in general are under so much pressure. I think the likelihood of any of that conversation is virtually nil. Kevin, can I be really honest? Can I ask you a question which is in a sense relates back to, we are amongst the highest prescribers in the country, 4,042, I think is the old ICB model. What's the experience elsewhere? I mean, a lot of people worry about harm. And if I went to one of those ICBs, does it feel different? I mean, have we got any evidence either way, by the way? That's you know, we're the outliers now, not the other way around. We're bringing ourselves into line on this. Is there any evidence?
So evidence of,
well, either harm or difference or varying or anything that would enable me to say, oh, that's what it would, because it feels to be the fourth most generous prescriber, it does feel We're the ones out of still.
So there's a mixed picture across the country of ICBs that have stopped completely and don't allow anyone or have some type of exceptionality. Within those, none have done any follow-up yet or published any follow-up, let's put it that way. That suggests that stopping it has caused harm. So we've got areas that it doesn't really fit with deprivation or not. So you've got some areas of high deprivation, that have stopped completely, and some areas of very low deprivation that continue. Okay, so there seems to be no big number, which is why what we're saying, as part of this, we would continue to monitor, inputs and stuff to see what's going on. No, there's no documented evidence being released yet about what this would, any follow-up. Okay.
Sorry, I just thank you. Dave.
Just to go back to Kevin, so we know we've got Tristan Humphreys on the call from Senior UK. In our conversation we did raise that thing about how do we lobby, politicians or the government to consider this. I recall our conversation, it being not very high up on the priority list, Kevin. So that's the challenge we've got here. We've got a small group of people, very important for these individuals, but from a national perspective, it kind of doesn't get the kind of quite presence that you would hope that it would do in consideration. With regards to the impact, I mean, we would look at things like hospital admissions, referral rates into hospital, and so those were the proxy markers that we were intending on reviewing and feeding back on.
I mean, I guess given what you both just said, what I'd want to see, I think what the board would want to see is that we did follow this up. So it wasn't just that we did it, but 6, 9 months, 12 months later, we should look, this is what it looks like. The fact that others haven't produced that is for them. Actually, I'd quite like to see what the impact was. As chair here, Leslie, sorry.
Thanks, Chris. I mean, we had a really good report yesterday, which has been a follow-up on the non-emergency patient transport changes that happened a little while ago. And gave us some really good evidence about impact, but also mitigations that have been put in place after the event. And I think we all agreed at the committee yesterday that would be a really good way of following up. So I think that we can take on that role and do that follow up with David and the colleagues.
Quickly, I think I just want to make sure it's done. That's all I'm saying. Greg.
Just on impact, David, I'm not convinced that you're better to measure impact in the healthcare system. I think the impact is going to be in people's pockets, a relatively small number of people, but with lower incomes because they're paying more in supermarket prices, etc. And I think we've got to be for what it's worth. My cards on the table is a strong preference for option 2. I think that's where we won't go, but that's where I am. It's a sort of a impact on income and equity point, and I don't think we'll be able to measure impact on healthcare system indicators because 1 is too messy, 2 it's just low numbers. We've got to be mindful of that.
Richard. And then,
it's a follow-up question, because in the introduction, I think there was a statement that said it has high impact on inequality. My apologies if I missed in terms of, is there a disproportionate uptake in terms of the current system that we use inequality based? We know that in certain private populations that don't access general practice in the same or similar numbers to other areas. So have we got inequality already that will potentially make worse by the fact that access to general practice is very deprivation?
The biggest inequality we've got is half the people that we think we see their SCs don't even know they've got it. So before we get into those who are accessing prescriptions, that's a biggest group of people, and they can't make a decision if they're not even aware that they've got the condition.
That's what we meant by the high impact on inequality.
No, we think finances, as Greg has highlighted, is a consideration that people who are more deprived are less able to make the choices, and we can't mitigate against that. So that's as I said, we've done our best to we can educate people, we can try and support people, but ultimately we can't replace. We are taking something away, Richard, and there is an impact on doing that. The other variations, we noticed that each of the 4 places we have different percentages of people seeking prescriptions. So once again, that would jump at me to say is that people's awareness of gluten-free products on prescriptions is different across South Yorkshire. Now, if we move to the new model, I guess there's a lower, lower number of people in the exceptionality group. So,
Moira, thank you.
Thank you. Just a point of clarification really in relation to the three options. I'm just wondering whether at Quigley or in the discussion with the executive, what was the decision making around option 3, which was to continue to provide prescriptions for under 18s, as opposed to option 1, which I know was a recommended one.
so that was the preferred option that we originally set out. However, that wasn't part of the conversation at Quigley because it didn't feel it was more about the process we went through with our engagement. I think the feedback we got is that people were, elderly were excluded in that, and that didn't meet that. We believe there's 1 or 2 ICBs in the country who have gone for the under 18 category. By choosing option 1, it's agnostic of age, so exceptionality would include
The under 18 as well,
people who are elderly.
Actually, that's a helpful way of describing it, David,
Yeah.
which I haven't quite picked up, so thank you for that. Any other points people want to raise? Really?
Quickly check the numbers then. So under option 3, the savings grades for prescribing it to children.
That's right.
Why the biggest saving by prescribing?
For those that accessed prescriptions, there was fewer people under 18 that we found access it. So if that was to be reduced, you get more things, if you see what I mean.
Okay. Any other questions? Can I just check the board that we've addressed the questions that you raised at the start, Andy?
I think we have, Piers. I think
Yeah, I think we have.
there was a discussion on exceptionality, and I think just to break down the language barrier to people online, I think that is very much a discussion around clinicians being able to have flexibility on those at risk of clinical harm. So just to clarify that discussion.
Okay. People comfortable with that? Sheila?
Just a question of mitigation that was raised. I know we've kind of talked about that we do a follow-up and kind of assess the impact, but I think we really need to kind of have that home in a way that kind of just gives a bit of assurance to people that are asking that question around mitigation. Because I think for me, it makes a point about kind of the cost of living, kind of looking at it. There's certain things that we can measure and certain things we can't measure. And I think it's important that with the patients that are involved in this, we get an understanding of actually, are there ways, and it might be a system approach as opposed to just an ICB approach, whereby we're looking at people who are impacted by, what areas of deprivation in South Yorkshire do we have these patients in, if we're talking such small numbers of patients, and also kind of getting a view of a mechanism. I haven't got the answer to this, but thinking about an approach or a mechanism that gives those patients an opportunity to say, here's how it's financially impacting me, even though we may not be able to do anything about it. But if it could be something in the future that helps us to kind of at least say, we recognise it in our quality impact assessment, but how we can't mitigate against it, but how we at the very least recognise its impact on people as we start to implement these decisions.
I think Greg's right. The difficulty for the NHS, and we are an NHS body as such, it's very, very difficult for us to measure that kind of broad issue. It's arguably impossible for us to do it. We just have to be honest about it. That makes this really challenging. Likewise, whatever people think, when they use the word vouchers or something, we can't distinguish on the grounds of income. We're not allowed to. The only way the NHS does that is by national statute, like on prescribing. Some people pay, some people don't, or dentist people pay, some people. We can't distinguish on income. We're not allowed to. Can't set a different income standard in South Yorkshire than we can somewhere else. That's what we're. That's actually the position we're in. So we can do our best to monitor the impact of this, and ask the team to do that. But I think we've got to be honest with this board. Will we pick up every nuance of this in the community? We can't. It's really impossible. And it's certainly impossible for us to do it as an ICB. And I think, by the way, that could be true of so many issues. It's just exposed on this.
So what we can measure is access to services and health outcomes.
Yeah.
So that's what we use our evaluation.
Please.
And so it was just from one of the questions. I think there was a question about support. What support are we going to offer to dietetics? I'm not sure if we covered that, but we have got reduced resources. So I don't think there would be any extra resources to offer to them. It's just so that we answer it.
Yes, that's fair. Okay. Happy with discussion, people happy to move forward? So I think I'm going to read out the whole thing, which is, if I sound, to ask the board to note the contents of the paper, to note that option one is the preferred option, which is the one we discussed. In deciding the guidance for prescribing bread and flour mixes across South Yorkshire, we're aligning with other ICBs, but we do accept openly it will have some negative impact. We consider the views of the consultation process the last 12 weeks. Grateful, Katie, for the work you've done on that. It's really helpful. And to approve that option one going forward, which means that we will be reducing access, one, but that we try and implement with clear patient communication and ongoing monitoring of health service impact. Being honest, it can only be health service impact. Are people happy with that as the basis? Okay. Thank you very much. Thank you for the team. That is now agreed. Can we move forward to the commissioning of IVF services? And David, you're going to do the introduction on this as well?
Yes, slightly different IVF thing, because we've got three separate considerations, although they are interconnected. So Lisa's going to help support me through that, because the first point of infertility treatment is our access policy, and you'll see within the paper that has been updated, so it seemed timely to bring that alongside
as well
the other decisions.
So that's technically not about limiting IVF, but it is about the access policy. Okay, I have picked it up. Thank you.
The two elements of that. So there's the infertility treatment commissioning policy, and there's the Yorkshire Humber fertility preservation commissioning policy. So public questions.
Oh, yeah, questions. Sorry, Lisa, I delayed you. I apologise. Andy, you want to put questions?
Yeah. Yes, absolutely. So, so we have two questions from members of the public on this. The first is from Councillor Gemma Cobby, and I think Councillor Cobby is able to join us online today. Councillor Cobby represents the Town Ward in Doncaster. Her question is, have the ICB researched the potential impact of reduction of IVF on the future population of South Yorkshire? The average age of a mother giving birth is now 31 years old and is increasing year by year towards the mid-30s, with couples and individuals meeting and making choices later in life, along with other well-developed countries such as Japan struggling with declining birth rate and a high aging population. So a question about future population. And the second question is from Anne-Louise Bailey, who's unable to attend the meeting, but represents Doncaster Violence Against Women and Girls. And the question is that unfortunately in South Yorkshire, many people and couples cannot afford private treatment. Therefore, this will impact those on low incomes and have the effect that this will impact the population in South Yorkshire in forthcoming years. Has the ICB considered the economic social divide and the proposals and acknowledged the Human Rights Declaration on the right of a family? And follows this with, how can anyone put a price on a family's head?
Thank you.
I think we'll start off with the policies, if we may, and Lisa, if you could just pull out the differences or the update, please.
Lisa.
Yeah, thank you, David. So the Yorkshire Humber Fertility Panel have developed over the last 15 years or so the access to infertility treatment commissioning policy, and also the crowd preservation, fertility and preservation policy as well. Both of those are being updated largely to reflect the nomenclature of the ICBs now being statutory body of the region in terms of the three ICBs that sit within it. The clinical criteria within both of those policies continue to be the same, but what the fertility panel had the opportunity to do when they updated the policies was to make it much clearer for the reader to understand what that eligibility criteria means for them. So I wasn't going to go through the specific details of that, but I have included a table for each of those policies within the document that sets out the differences and what the impact of that is. And as I say, I don't think that there's a negative impact on either of the policies in terms of the update that's been made. And just to add, the other two ICBs within Yorkshire and Humber have also adopted them too. So
just pause there, Lisa, because we have included 3 impact assessments. 2 of the impact assessments are on the policies. So the impact panel assessed these as low risk. So we're hoping these have been updated. As Lisa said, they've just been brought up to date with regards to reflect ICBs rather than CCGs. The only thing we will pull out is within the first policy, the number of IVF cycles is part of that. So when we make a decision, that will be threaded into.
The main debate will be about the number of IVF cycles, but you want us to agree the revised policy, which is now consistent across.
yes,
Oh, that's really helpful. Thank you. Let's do that in 2 stages, if I may. Come back to the single cycle. Are people happy that we update the policies as Lisa said? Great. Thank you. Thank you for that, Lisa. Can we move then on to the cycles, which I think is the debate we want?
yes.
Please, is it Lisa? Will you lead?
I'm reading it.
Yeah, brilliant.
And Katie will do it.
Brilliant. Thank you,
piece
Lisa.
on,
Thank you.
Thank you, Piers. So apologies that there's a substantial amount of papers within the pack for the IVF commissioning policy review. I thought that demonstrates the comprehensive and kind of complexity of the review that we've undertaken around our commissioning policy. I thought it would be helpful just to do a very quick context and background. Some colleagues will recall in 2022-23 that we undertook a commissioning policy review of IVF, which was to largely align the number of cycles that we commission and we offer to eligible couples, which we aligned across the board to 2. That was decided by board on March the 1st in 2023. I think given what we've heard today around the financial pressures in the NHS, it did require us to come back and look at the number of cycles that we are commissioning. And the paper sets out the outcome really of that policy review, but also some of the findings that we've taken. We've taken a very strong EQIA kind of lens and focus on this. We recognise that this will have some significant impacts on parts of our population. I'll come to that shortly. In terms of I guess the where we stand nationally, what's our comparison with the other 41 ICBs? The majority of our ICB colleagues fund 1 cycle. With you can see on page 10 of my paper the number of cycles that are funded across the board. So 67% of ICBs in the country fund 1 cycle. This is taken during 24-25. 19% of ICBs fund 2 cycles, and we're currently within that band, and then 3 cycles are only funded by 10% of ICBs across the country.
Lisa, if I could just come in here, we know a number of ICBs are also going through the process that we are today to review that.
I've also included a table what NICE recommend as part of their clinical guideline 156, which was written in 2013 and has had numerous updates over the last 15 years or so. The latest update was 2023, but still stood that they recommend for women under the age of 40 to have three full cycles, and women aged 40 to 42 to offer 1 cycle. NICE are currently out to consultation with the change to their policy and clinical guideline, but that's not due to be concluded until Q4 or Q1 26-27. In terms of the impact of having 1 cycle, on section 9 in the paper, I've included a table that sets out the live birth rate that would be expected for someone at the age that they would be undertaking IVF. As you can see, there's a decline in the opportunity to conceive the older that the woman gets. with the average of, with one cycle, a live birth rate being 25 to 26%. In terms of the anticipated savings and spend on the spend that we do from an IVF perspective, and specifically looking at the second cycle, overall we fund £1.97 million worth of IVF treatment to our fertility units across South Yorkshire. That was the figure for 24-25, and of that, 400k is associated with the second cycle. We would expect that if we were to make the decision today to reduce cycles from 2 to 1, that we would anticipate the 400k saving. However, we do need to consider what the potential impact might be on the reduction in cycles for people, couples, from a mental health, anxiety and distress perspective. Just thinking about the exceptionality aspect for some couples, there will be and continues to be an opportunity for clinicians to make a case for an individual or a couple to have funded services outside of clinical criteria where the case is strong, and that does continue to be possible for IVF and will if the decision is made today to move to one cycle. I do want to talk somewhat about the Equality and Health Inequalities Impact Assessment. So you'll have seen within the appendices, David just mentioned the EQIA approaches that we've taken. Recognise that from the assessment that we've made, that the change will most significantly affect women and people and families on low incomes and those living in areas of higher socio-economic deprivation. And considering that 40% of our population in South Yorkshire live in the most deprived communities within the IMD scores of 1, we do recognise that this will impact on individuals, particularly those who are not able to self-fund their own cycles, where a cycle could cost up to £6,000. Women are particularly impacted because fertility primarily affects them biologically and can be exacerbated with gynecological conditions that are more prevalent in women. And they are further amplified by women living in more deprived communities. And also women from minority and ethnic minority communities, especially Black and Asian women who are already experiencing lower IVF success rates. A reduction in cycles is likely to have a psychological, emotional and mental health consequence for couples and families, as the stress of infertility and unsuccessful treatment is linked to depression, anxiety and a sense of loss of hope. And we've heard that very strongly in the involvement exercise that we've undertaken and the feedback that we've received. So the proposal, is important that the board recognises and considers this in its decision, that the proposal does risk widening health inequalities that is contrary to its statutory duty to improve health inequality and outcomes for its population. We have undertaken a comprehensive involvement exercise. I didn't want to add anything further from what you said earlier around that from an IVF perspective. Shall I do the key things? Yeah. So similarly to the gluten-free, the involvement exercise ran for 12 weeks from the 28th of July to the 17th of October. And similarly, we've received extensive numbers of feedback from various different routes. We had 1,706 people respond to the survey, 5 pieces of direct correspondence, small number of social media comments, telephone one-to-one and focus group conversations. They are all included in the packs. Everything that we've received within the consultation period has been included in the packs, including the transcript from the Doncaster Council meeting. Similarly to gluten-free, respondents who provided feedback via methods other than the survey didn't answer the quantitative question about which option they would prefer. However, feedback indicates that a significant majority were opposed to reducing the current offer. Of those who responded to the survey, 82% indicated they preferred to continue to offer up to 2 funded cycles of IVF as per the current policy. 8% preferred other, which included offering the NICE guidance of 3 cycles in the comments, 5% preferred option 2, which was to reduce provision to 1 funded cycle, the preferred option, and 5% preferred option 3, which was moved to no cycles. The main themes that were raised, and again, many stories, and I really hope people take the time to read the stories, because as you know, David said about gluten-free, my team and I have read them all, and they are quite a difficult read there. So but these are the key themes that came out of them. The first one is right to parenthood. Becoming a parent is widely viewed as a fundamental human right, and that infertility is a medical condition, not a lifestyle choice. There are references to NICE and WHO supporting NHS funded IVF. Emotional and psychological impact. Infertility and restricted access to IVF are described as emotionally traumatic. Respondents cite depression, anxiety, grief and hopelessness, and warn about knock-on effects to NHS mental health services. Clinical effectiveness and need for multiple cycles. People highlighted that NICE recommends up to 3 cycles. 1 cycle is often insufficient. There's reference to success rates improving with multiple attempts. Fairness, equity and postcode lottery. Stakeholders call for national consistency in the access to IVF. There's concern that reducing cycles would deepen inequalities, especially for low-income families, same-sex couples and those with specific medical conditions. Financial hardship and socio-economic barriers. Private IVF is prohibitively expensive for many and can risk pushing families into debt, with the cost burden disproportionately affecting lower income individuals. Themes of debt, selling assets and delaying life plans were common. Risks of unsafe alternatives. Concerns were raised about individuals turning to unregulated or unsafe alternatives if NHS funded IVF is reduced. Gender impact and representation. A number of respondents felt that women are disproportionately affected by reduced access and questioned this at a time when gender inequality in health services is supposed to be being tackled. Often delayed diagnosis for conditions that cause infertility meant that people felt the policy could be unfair. Eligibility criteria and barriers to access. Restrictive eligibility rules based on age, BMI, relationship status or previous children are seen as unfair and frustrating. Therefore, calls for more inclusive policies with trans and non-binary individuals identifying unique barriers that they face. And I think that is one of the themes that came out that isn't actually directly related to the debate we're having today, but it felt fair to include it because it did come out. Cost versus value debate. While some support reducing cycles for budgetary reasons, there were people who did understand the financial situation the NHS is in. Most argue that financial savings are minimal compared to the emotional and societal costs, and some claimed that cuts may be a false economy leading to increased costs elsewhere. Within our underserved and marginalised groups, focus groups and community leader feedback reveal IVF is a taboo or unfamiliar topic in some communities. There's a lack of awareness, mistrust of services and assumptions that IVF is only for wealthier people. And then finally, there was a strong call from people to include lived experience, which hopefully you'll see we've done that in the papers. Thank you.
Thank you. I just have 2 more points to make. So in terms of concluding, I think the review has been very difficult. It has been really robustly undertaken. It is emotive, but it does highlight the complex balance between the ICB having to meet its financial sustainability and the statutory duty it has around increasing health inequalities. In terms of the saving, I've already pointed out that there potentially may well need to be an increase in mental health and counselling services, but that's something that we'll need to monitor as part of our ongoing mitigations, and they are captured within the QIA that's within the appendices. And it is important that when the board make the decision that they understand what the impact is for people that are already currently in their cycle pathway. So whether or not a change in cycles from 2 to 1 is for new patients that haven't yet been referred in for their IVF treatment. I'll leave it there.
So I've just got one additional point. So I think the board should note that NICE are undertaking a review at the moment to assessment and treatment of fertility treatments. This came on the back of a press release that said that several popular fertility add-ons were being offered that have no evidence. So that's expected to publish in March next year, so we'd have to take that into consideration, but we don't know what the outcome of that's going to be, so it's just for people to be mindful that there may be some national guidance that changes, of course.
Chris?
Just a context, when we first formed the board 3.5 years ago, one of our first decisions was decide on cycles of IVF. So we inherited a position of Sheffield for many years practiced 1 cycle, Rotherham, Doncaster and Barnsley with 2 cycles. So we have seen the impact of both this decision. At that time, even though most of the country was on 1 cycle, we chose to make the decision to be 2 cycles. But I think why it's here today is we're reconsidering on the grounds of affordability because the financial situation has changed so much. So we now need to reconsider on those grounds. With experience of both situations running in on different places, so people might not recall that. So just saying that.
Thank you. Any questions from the board, please? Leslie?
Comment first, please. So just similarly to what I said about the gluten-free item, we've done the same level of scrutiny in terms of the consultation process and the responses to that on this item. I just thought that was worth noting. And can I just check out, so this is a question, can I just check out what are we saying about people currently in the system to retain the 2-cycle entitlement?
I think in the board paper, in the recommendations section, I think what we've suggested is those people that have been, let's hold it, 6.5 on there, who've already been referred for infertility treatment and by their clinician and have been and are undertaking the treatment. So at the point where the clinician has decided IVF is the right fertility treatment for them, if that's met.
Yeah, they would have had that discussion with the patient or the couple on the basis of the policy that we have now. And I think that is what that point is trying to know.
Can I just use my language for that, to make sure I got this right? So that if a couple are in the system, have been assessed, have been told they'll get IVF because they're in that position, and be told they'll get 2 cycles, they will get 2 cycles.
Yeah.
My assumption on that, on the money, therefore, just to make sure I understand this, is that the money will not be a full 400k probably next year for those people.
Yeah.
Okay.
At the moment, we haven't been
It
able
would
to
be fully,
quantify
probably
how many-
400 year and a full year effect, but there will be an impact into the next
Yeah,
6
that's
months.
leading.
Yeah, okay, sorry, that helps me understand it. You might all have understood that, you just helped me. Greg?
Cheers. A few quick thoughts. I'm very mindful of the add-ons that David mentioned. I think they need to be dealt with, 1 by NICE and 2 by the access criteria really robustly, because I agree there's a whole bunch of really low value add-ons that shouldn't be within NHS care. For what it's worth, I argued very strongly against the 1 cycle in Sheffield CCG, I think it was at the time. I would continue to argue against moving to 1 cycle on all of the well-trod grounds, justice, fairness, equity. I'm not convinced this is the biggest target in terms of affordability. We can all cite bigger targets. I think the justice and inequality arguments would make me stick with 1. I accept make me stick with 2 cycles, aka the current position. I accept the board may well go to 1, but it wouldn't be 1 I would vote for.
Great, thank you. Any other points? Richard?
So, one of the things in the paper is this issue of affordability realistic with different groups and the potential inequality down financial basis. And one of the other commitments we've got in all of our places, I think, is the first 1,000 days. So I think we may already know that moms, families, dads to this from a low socio-economic are then potentially going to put themselves at greatest financial hardship, which will then mean that those children successful pregnancy will also have probably a more difficult first 1,000 days. So this one I think is equally as tough as the last one in that respect, but also on some of the other issues that were in the questions or otherwise about for birth rates to maintain birth rates, inequality, and but also that aspect of people in service, not sort of clear people say about the comments, especially one of the comments, I don't think we should know that or I think this one we talking about basis. This, the urge to hold the family as we said that you cry and finances, I understand.
Can I just understand the health inequality issue? Just from my perspective, and I'll frame it in a different way. What we're proposing here is one cycle for everybody, regardless of income. Stop. It used to be 2. Stop. There is clearly a risk then that people think the only way I can get this is to pay for it. And that's the health inequality issue, is they might want to pay for it rather than anything else.
There are a number of health inequalities, largely because of the fact that there's a disproportionate impact for different parts of the population, particularly ethnic minorities. But I think from a financial point of view, I would agree with you.
Yes.
It does make it more difficult for people who are living in those more deprived communities that are on, lower paid income jobs to be able to afford to have sex desire.
The other issue, I was implicit, maybe some work we need to do, is I've seen evidence, and it was implicit in this, Lisa, that actually our access to, forget whether it's 1 or 2 cycles, our access to infertility today is not equal on the band, that actually, bluntly, the middle class have always accessed it more than people from deprived communities. So forget whether you pay for 1 or you pay for 2. And we're asking the board to agree to move from 2 to 1. Actually, there is broadly a health inequality issue in infertility, isn't there? Am I right in that?
We haven't quantified it in the paper, but I would suggest that there may well be. And I think one of the other considerations is how we can ensure that we have quicker access to the utility services that our hospitals provide, and that's something that we'll look at with our providers.
Yeah, there's an issue there. All right, so
So the question we had from Councillor Coley was about have we considered the future population of South Yorkshire? So the BI team have had a look at this. The proposed changes are expected to have a small change in the overall birth rate that we see in South Yorkshire, and an even smaller impact on predicted population growth that's been there. I would like to add just one additional thing, because Richard, you just prompted me that Human Fertility and Embryology Authority, they produce some statistics. 3% of all births in the UK are conceived through IVF, and a quarter of them are funded on the NHS. That should give somebody, people a bit of a realistic thing that IVF births are still a small number, and the ones funded on the NHS are even smaller number. So anyway, just thought I might be on.
Thanks for that. I think, Jenny, did you want to say something in the middle?
Yeah, I think Lindsay's got that.
I saw you have.
Yeah, I think you raised a question about kind of deprived communities and those that particularly don't have access. I think there's also, for me, an issue around kind of awareness, and I know you're going to go and have a conversation with providers, etc., and so on and so forth. I think the worry for me is, whilst we're kind of having this discussion, again, it's irrelevant if it's 1 cycle or 2 cycles, we're having this overarching discussion about IVF. I think there is something in there sort of niggling and worrying me a little bit, that the more awareness we raise about a topic at the same time that we are reducing the services about that topic, and it just feels a little bit, I've read the stories, I can appreciate how difficult, so I can only commend and thank all the staff that have been involved in this, because they were really difficult to read. I think the thing that worries me slightly is, yes, I know we'll kind of come to whatever decision we come to, but we are talking about real people. And for me, it's not so much about future birth rates, it's about the people in the system now, and it's that kind of mid-term impact of people that are coming to those points in life where they might start making those decisions. But the bit that worries me is that those people in the system, that particularly women who are affected by gynecological health issues, that may not even be aware right now that infertility is a potential problem for them, and it might be something that comes later down. So I know it's a really emotive subject, and it's been a really difficult one, but I just think I just wanted to flag that, in terms of health inequalities, I think sometimes we get too lost in statistics and numbers and tables, but ultimately we are talking about people here as well. So I just wanted to acknowledge that all of the people that have been involved in your consultation and involvement, or people that have asked the question, I can only with great humility, thank them, and just to kind of say this is not going to be an easy decision, whichever way we go.
Thank you. Leslie, you want to say something?
Yeah, just in terms of this, the impacts that making this decision are going to have on people's health more generally. You know, we talked in the last paper in this way about how can we monitor those impacts and understand actually, you know, I think somebody in the consultation said it's a false economy, my words, it's a false economy this, because we're going to just create other health needs in other places. And I wonder if we can find a way of following up on this to understand some of the impacts and whether then further mitigations can be put in place.
Yeah, I think following the decision that we make today, there's a conversation and a continued one that we'll be having with our providers, with our fertility units and consultants and the teams about what the impact of this is. And we, because, you know, from a referral to counselling and mental health support comes from the fertility units, so they kind of hold the care pathway together that way. My point in the paper is we don't know if that will be sufficient if it does increase, and so that's something we'll need to keep very closely working with our providers to understand what they see in the next few months around the impact on an individual level.
Thanks, Lisa. Please, we could talk that.
Okay.
Come back to the board.
Well, maybe or somewhere, yeah.
Yeah, somewhere. Yeah, please.
Christine, final word.
Thank you. Just a comment around the scale of the savings, and I know in this conversation today we've zoomed in very much, haven't we, onto two particular decisions, and I just wonder if there's something else for us to take away as a board to say, show this in the context of the whole and other decisions that we're making. So it just feels very, it obviously has been a very specific discussion, but it is part of a bigger picture.
I agree. I was going to say something, Christine. So let me. We're making two decisions today that save sums of money that, in the context of the rest of our budget, don't look great. They're not large. Maybe that's a better way of putting it. I think, however, and we've got a discussion, informal discussion after the board meeting. We all know that the level of change we have to deliver, the level of saving we have to deliver over the next 3 years, because we've got a 3-year budget supplement. These two changes will dwarf what we will be doing over the next 2 to 3 years. We just need to be honest with each other about that. These are small scale savings that we believe we can make because they're explicit commissioning decisions. Nothing wrong with that, but they are the start of what I think that we should be honest with ourselves. The next 2 to 3 years are going to be extremely uncomfortable for the levels of savings that we have to make and demand of our hospitals and providers. And all of us know that. The next conversation we have for our informal discussion after a gap here is how do we begin to do that? But it's a conversation we've had before. So I think it's a point well made, Christine. It's going to get more and more difficult. We are going to have more and more of these discussions. That is the lot of the strategic commissioning role that we've been given. I think we all know that. I think that is what we're going to be doing over the next 2 to 3 years. Okay, are people happy? Richard, sorry.
Can I just understand a little bit more about the care pathway? In essence, I think what we say is that if you're in the system now, you're in the system, and therefore the Christian intention is now stamped.
Yes.
And they will be on it. But there is a waiting list, isn't there? As I understand it. So the waiting list is considerable.
So I think, let me be clear what I think we said, then you can correct me if I'm using my language. If you have been seen and assessed as requiring IVF, because some people get to it on a waiting list and do not get to IVF, it's not the appropriate treatment or whatever. If you have been seen as assessed as requiring IVF, you will also have been told that you've got a right to 2 cycles. Those people will get 2 cycles because they've been told that. Being on a waiting list does not automatically give you 2 cycles. That's the distinction we're making. Am I right, Lisa, in that?
That's right. Yeah.
That's the bit I'm just trying to clarify in terms of at what point in this next financial year does that like that commitment kick in? When does it kick in?
So it kicks in. I think we won't make 400k next year for the reasons I've said. It kicks in from now. If you've been seen by the team and have been assessed as requiring IVF, you were told that you get 2 cycles, we will honour that, which means the savings next year, because some of those will get treatment for 6 or 9 months worth next year. But if you're on the waiting list not yet seen, you will only get 1 cycle.
Yes, I understand that in the context of what you're saying. What I'm really asking, probably in a candid way, is that in reality, is that a decision for now, for next year, or is it a decision for the year after?
It's a decision for now. The decision is made today if we make it 1. But we recognise those people who've been seen will get 2 cycles as promised, which might mean the same, well, will mean the savings next year are part year. I could not tell you if we could go and evaluate it exactly what it would be, but I'd expect the savings next year to be less. But by making the decision today, the full year effect will be 400k.
No, I'm understanding that they're not getting across what I mean in terms of the management of that waiting list and when the decision comes to what's it, if you like, new couples.
From if you haven't been seen, it's
If you haven't been referred in for IVF treatment by the consultant, the medical team within either care or SOPs, you wouldn't be able to have 2 cycles.
Yeah.
So it's where you've already had that conversation as a couple with the clinical team.
okay. We've agreed already the reconciliation of the system itself. Let's not go over that. This is, are you happy to go forward with the model to move to 1 cycle of IVF treatment for those people who've yet been seen by the teams, to use that distinction? People comfortable with that? Or are they prepared to agree? It might be a better word than I think we're prepared to agree. Thank you very much. Thank you, everybody's online. That is the end of our meeting. We've got an informal discussion on the money and the planning next year. Do you want to take we'll make that 11 o'clock, everybody. Is that all right?